So heparin is just one option that we have for DVT prophylaxis. The other option that we tend to use as well is called Lovenox. Lovenox is also known as Enoxaparin, and it's considered a low molecular weight heparin product. So it's still related to heparin, but it's considered low molecular weight, meaning it's a smaller molecule than what heparin is. In terms of the mechanism of action for Lovenox, it also works on antithrombin 3, but it has more of an effect on factor 10A than on thrombin itself. For this reasons, if you wanted to monitor the effects of Lovenox in a patient, you would check an anti-10A level. But because it's so predictable in terms of how it works, we actually typically don't have to monitor them, especially if you're just doing it for DVT prophylaxis. Another advantage of Lovenox over heparin is that it's only a one time per day injection, whereas subcutaneous heparin you may give 2 or 3 times a day for DVT prophylaxis. A couple downsides with Lovenox, you're just using it subcutaneously and not intravenously. And so if you are trying to plan procedures around anticoagulation, you may have to wait a longer time for the Lovenox to disappear from the body or go to a subtherapeutic level before you do something like a neuroaxial technique like a spinal or an epidural for patients who are on Lovenox. You also typically want to avoid Lovenox in patients who are on renal failure because that's how they get rid of the medication is through their kidneys, and so you don't want them accumulating Lovenox when they're in renal failure. Another place where you may see Lovenox being utilized is in the pregnancy population, where if you have a pregnant patient who has antiphospholipid syndrome and is on anticoagulation with Coumadin, you're going to want to get them off Coumadin because that can be harmful to the baby. So you may transition them to Lovenox and have them take that as an outpatient for their anticoagulation. And then in terms of major contraindications for using medication like Lovenox, obviously if somebody is bleeding, you don't want to put them on a blood thinner. Also, if they have a hypersensitivity to Lovenox, you're not going to want to use it in those situations. If their platelet count is below 50,000, we tend to avoid any anticoagulation like Lovenox. And lastly, if you have someone again who you're anticipating is going to either go to surgery or have a procedure done, typically these patients are going to be put on IV heparin infusion, especially if they need total therapeutic anticoagulation. This is just easier to turn on and off and have more control of their anticoagulation status as opposed to just doing by twice a day dosing of Lovenox. And lastly, just to clarify that last point, there's really two reasons why we use anticoagulation. One is in terms of DVT prophylaxis, and the other is full anti-coagulation therapeutic dosing. So DVT prophylaxis is really anyone who comes in the hospital who's critically ill and we're trying to prevent any sort of thrombus forming, whereas the full anticoagulation that's at therapeutic level are for patients who are at increased risk for forming clots, like if they have atrial fibrillation, if they currently have a clot, like if they have a pulmonary embolism, or if they had an unprovoked clot in their past history, they're likely going to have anticoagulation for a prolonged period of time and potentially even lifelong.